Welcome back to the deep dive. Today we are taking on a true giant of medical surgical nursing, heart failure.
Oh, absolutely.
This is probably the single most important, complex, and frequent condition you will encounter, especially if you work with older adults.
For sure.
Our mission today is to take one of the best texts on this chapter 25 on heart failure and complications and treat it like a high-yield clinical crash course. We're going to cut through the jargon, really synthesize the core pathophysiology, and most importantly, pull out those non-negotiable nursing interventions.
And that mission is just so critical because the reality of heart failure, or HF, it's pretty stark. The sources make it clear this isn't just a disease, it's an epidemic.
A public health crisis, really.
Exactly. HF is the leading cause of hospitalization for people over the age of 65 in the United States. And we have to understand, HF is a clinical syndrome. It's the end result of some other structural or functional cardiac problem that just impairs the heart's basic job.
Which is to fill up with blood and then pump it out.
Right. It can't fill properly, or it can't eject blood efficiently enough to meet what the body needs.
Okay, so before we unpack that whole cascade of failure, we have got to set up the vocabulary. For anyone learning this, these definitions are the absolute foundation. Let's start with the central clinical measurement. Ejection fraction, EF.
Right, the ejection fraction. This is the key quantitative measure of, contractility. It's the percentage of blood volume that the ventricle actually pushes out during a single contraction, during systole.
Okay, and in a healthy heart, what are we looking for?
In a healthy heart, you expect the EF to be between, say, 55 and 65%. Anything outside that range tells you there's some functional impairment, and how far outside that range really dictates how we classify the heart failure itself.
And those classifications are basically the roadmap for treatment, right? We've got three main types based on that EF number.
Exactly. So first, and historically the most common one, is HFrEF. That's heart failure with reduced ejection fraction.
So the R is for reduced.
Right. This is what we used to just call systolic heart failure. The muscle itself is just too weak. It can't squeeze hard enough. And the defining cutoff for this is an EF of 40% or less.
So that's a pump problem, a squeeze problem. What about the other big category, the one where the squeeze actually looks fine on paper?
That would be HFpEF, heart failure with preserved ejection fraction.
Okay.
The P is for preserved. We also call this diastolic heart failure. Here, the EF is 50% or greater.
So the number looks good, but the patient's in failure. How?
Well, the issue isn't the contraction strength, it's the relaxation and filling. The ventricle is stiff. Usually from years of high blood pressure or something like that. So while the heart ejects a good percentage of what's in there, the problem is it couldn't take in enough blood in the first place. The overall volume is just too low for the body's needs.
Okay, so that's a critical distinction. In HFpEF, the tank didn't fill up enough because the walls are too rigid. And then there's that little category in the middle.
Right, the emerging third category is HFmrEF, heart failure with mid-range ejection fraction. This captures that group that's kind of in between 40 to 49%. And clinically, these patients are challenging because they often have features of both problems.
Let's quickly define two key symptoms nurses have to pick up on from a patient's history. These are just non-negotiable signs of pulmonary congestion.
For sure. We're talking about orthopnea first. That's shortness of breath that happens specifically when the patient lies down flat.
Why flat?
Because all that fluid that was sitting in their legs gets redistributed back into the central circulation, and it just overwhelms that failing left ventricle. And then the even more acute version of that,
PND.
paroxysmal nocturnal dyspnea, or
yeah.
PND. This is that sudden, terrifying shortness of breath that wakes the patient up from a dead sleep, forces them to sit up, rush to a window for air.
And we should also just quickly mention the kidney failure terms.
Oh, yes. Oliguria. That's a urine output of less than 400 millimolars in 24 hours. And then the most severe is anuria, which is basically no output, less than 50 millimolars in 24 hours. You'll see this as things get worse.
Okay, that sets our clinical baseline. Let's move into the scope of the problem. We're talking etiology and pathophysiology of heart failure. The sources point out the financial burden is, it's staggering. It's over $30 billion a year.
It's astronomical. And the reason is the readmission rate.
Right.
Despite all our advanced therapies, more than 20% of these patients are right back in the hospital within 30 days of being discharged. Managing this condition outside the hospital, that's the real challenge.
So who is most at risk here?
Well, the risk goes up significantly with age, of course. It affects men a bit more than women over 60, and we also see a higher prevalence in African American and Hispanic populations.
And then the usual suspects.
Oh, yeah. All the standard cardiovascular risks apply. Smoking, obesity, diabetes that's not well managed, metabolic syndrome. It's all in there.
And heart failure is almost always a consequence of something else, not a primary illness. What's the single most common primary cause that leads to HFrEF, the reduced kind?
It's overwhelmingly coronary artery disease, CAD.
Okay.
So when CAD restricts blood flow, you get ischemia. If that leads to a myocardial infarction and MI, you get cell death, necrosis. And that means a permanent loss of that heart muscle's ability to contract.
So the size of the heart attack determines the severity of the failure later.
Precisely. And that's why getting to the cath lab for a PCI or to the OR for a CIG is so critical. You're trying to limit how much muscle dies.
So CAD damages the pump itself. What's the biggest culprit for increasing the pressure the pump has to work against? The leading cause of HFpEF, the preserved kind.
That is chronic hypertension. High blood pressure. Hypertension increases the afterload. That's the resistance the left ventricle has to push against. So to compensate, the muscle fibers thicken. It's a process called myocardial hypertrophy.
The heart gets beefy.
Right, but it's not a healthy kind of strong. Over time, that thickening makes the ventricle rigid and non-compliant. It can't relax and fill properly during diastole, and that structural failure is what defines HFpEF.
And besides those two big ones, the sources also list things like cardiomyopathy and valve problems.
Correct. Cardiomyopathy is a disease of the heart muscle itself. And valvular disorders, like aortic stenosis or mitral regurgitation, just mean the heart has to work so much harder to move blood forward, and that workload eventually leads to failure.
And we can't forget the other systemic conditions that can drag the heart down, like kidney failure or arrhythmias.
Absolutely. The cardiorenal syndrome is a huge factor. Almost a third of chronic HF patients also have chronic kidney disease. And arrhythmias, especially AFib, just kill the heart's efficiency. You can't treat HF in a vacuum. You have to look at all of these other problems.
All right, let's get into the pathophysiology. This is that self-destructive mechanism people call the vicious cycle. For any student listening, this is probably the most important part to understand because every single medication we use targets a piece of this cycle. It all starts when the heart's output drops.
Right. So when cardiac output, the amount of blood pumped per minute, falls, especially in HFrEF, it triggers this massive alarm system in the body. The baroreceptors, they sense the low flow and they immediately activate the sympathetic nervous system, the SNS.
Okay, so this is fight or flight. The body floods itself with epinephrine and norepinephrine.
Yeah.
I mean, that sounds helpful at first.
It is, for about 5 minutes. The immediate effect is you get an increased heart rate and contractility. It's a short-term boost. But the long-term effects are they're catastrophic. The SNS causes this widespread vasoconstriction.
Squeezing the pipes.
Everywhere. The periphery, the GI tract, and critically the kidneys.
So the body is trying to shunt blood to the core, but in doing that, it's just massively increasing the resistance that the already failing heart has to push against. That's a huge increase in afterload.
Exactly. And that decreased blood flow to the kidneys, that triggers the second and even more potent destructive cycle. The renin-angiotensin-aldosterone system, the RAAS. Low perfusion in the kidneys basically screams dehydration, so the kidneys release renin. This whole cascade eventually produces angiotensin II.
And angiotensin II is the big bad guy we're fighting with our main drugs. It has two terrible roles.
Two terrible roles. Role number one, it is the most powerful natural vasoconstrictor in the body. It clamps down on everything, which spikes the afterload through the roof.
Right.
Role number two, it tells the adrenal glands to release aldosterone.
And aldosterone is all about holding on to volume.
Yes. Aldosterone tells the kidneys, hold on to sodium and water. So this fluid retention increases the total amount of blood coming back to the heart, the preload. So look at the whole picture. RAAS causes extreme vasoconstriction, increased afterload, and severe fluid retention, increased preload. You're forcing a failing heart to work harder against more resistance with more volume. It's the worst possible thing you could do.
And all of that sustained overload is what leads to the final irreversible damage, ventricular remodeling.
That's the structural consequence. All that strain, plus these damaging neurohormones, they cause the ventricle to dilate and hypertrophy in a really abnormal way. Myocardial cells start dying early, that's apoptosis, and they get replaced by stiff, fibrous tissue. That's the vicious cycle. The body's attempt to help itself is what ultimately makes the failure progressive.
But the body does send out a little bit of a distress signal, right? Even if it usually gets overpowered.
It does. That's the release of the natriuretic peptides, ANP and BNP.
B-type natriuretic peptide.
Right. These are released from the heart chambers when they get overstretched from all that high pressure. They try to fight back against the RAAS by promoting some vasodilation and diuresis, but Usually their effect is just too weak to overcome that massive SNS and RAAS activation.
Which is why measuring BNP is such a critical diagnostic tool.
It's literally a measure of how much stretch and distress the heart muscle is under.
Okay, so now we can make that leap from the mechanism to what the patient actually looks like, the clinical manifestations. For a nurse, differentiating between left-sided and right-sided failure is just paramount. Let's start with the left ventricle. When it fails, where does the traffic jam happen?
The backup occurs in the pulmonary circulation. You get pulmonary congestion. The left ventricle can't move blood forward, so pressure rises. It backs up through the left atrium and straight into the delicate pulmonary capillaries. Fluid then leaks out into the lung tissues and the alveoli.
And this is what causes all the breathing symptoms. We mentioned orthopnea and PND, but can you walk us through the actual physical mechanism of why lying down is the trigger?
Sure. Think about it this way. When you're standing or sitting up, gravity helps pull some of that excess fluid down into your legs and ankles. It's called dependent pooling.
Okay.
When you lie down flat, all that dependent fluid is rapidly reabsorbed back into your circulation. This causes a sudden spike in your circulating blood volume, and that surge of blood just overwhelms the failing left ventricle. That pressure surge into the lungs is what feels like drowning. That's the PND that wakes the patient up.
So what should a nurse be listening for in the lungs, and what's that classic non-pulmonary sound of left-sided failure?
In the lungs, we're listening for bibasilar crackles. These are sounds that suggest fluid, and the key is that they do not clear with coughing. As it gets worse, the cough itself changes, starts dry, then progresses to that classic sign of acute decompensation.
The pink frothy sputum.
Exactly. Large amounts of thin, frothy sputum, often pink or tan, which means you're in full-blown pulmonary edema. The critical heart sound you'll hear is an S3 heart sound. It's often called a ventricular gallop, and it means there's abnormal rapid ventricular filling against really high pressure.
And then beyond the lungs, you get all the symptoms of low cardiac output and that activated SNS.
Correct. The low flow makes the kidneys try to conserve fluid all day, but when the patient lies down asleep, the heart's workload is a bit lower. Renal perfusion actually improves a little, and that leads to that compensatory urination we call nocturia.
And for the brain.
Decreased oxygen and perfusion can lead to some subtle but really important signs: confusion, restlessness, anxiety, maybe some dizziness.
And the peripheral signs are all about that chronic sympathetic stimulation, right?
That's it. The body is vasoconstricting the limbs to save the core organs. So the skin is pale, maybe ashen, often cool and clammy to the touch. Peripheral pulses are weak, and the patient's usually tachycardic. The heart is beating fast to try and make up for the low stroke volume. And of course, just profound fatigue.
Okay, let's pivot to right-sided heart failure. If the right ventricle fails, where's the congestion now?
Now, the back pressure hits the systemic and visceral venous circulation. The right ventricle can't effectively take the venous return from the body, so pressure builds up throughout the entire body's drainage system.
And the cardinal sign of the systemic backup is what we can see right in the neck veins.
Jugular venous distension, JVD. That's the classic sign. We assess this with the patient at a 45-degree angle. Anything over 4 centimeters above the sternal angle is abnormal. And of course, you see dependent edema. It starts in the feet and ankles and just creeps its way upward.
And for patients who are stuck in bed.
The nurse has to religiously check the sacral area for that pooling. It's a must.
This is where we need to bring in that clinical pearl about just how much fluid we're talking about here.
Yes. This is so important for students to get. Edema isn't visible. The second fluid retention starts. Obvious pitting edema where you can press your finger in and the indentation stays, that doesn't usually show up until the patient has retained a massive amount of fluid.
How much are we talking?
At least 4.5 kilograms, or about 10 pounds of excess fluid.
Wow.
That's why the daily weight check is such a critical, non-negotiable early warning sign. By the time the patient's shoes feel tight, the problem is already severe.
And right-sided failure also means congestion in all the organs, like the liver and GI tract.
Right. You get hepatomegaly, an enlarged, often tender liver in the right upper quadrant, and ascites, which is fluid building up in the peritoneal cavity, making the belly swell. And all that abdominal organ engorgement leads to anorexia, nausea, and just general GI distress.
And when both sides are failing, which is common, often left failure leads to right failure. That's what we call congestive heart failure, or CHF. Let's quickly detail the progression to the absolute worst-case scenario: acute pulmonary edema.
Pulmonary edema is a rapid, life-threatening event. The pressure in the pulmonary system surges, and it forces a massive amount of fluid into the alveoli. The patient is essentially drowning in their own blood plasma.
What are those non-negotiable emergent signs a nurse needs to spot instantly?
Sudden, overwhelming breathlessness, a crushing sense of suffocation, severe tachypnea, and rapidly falling O2 sats.
What does the patient look like?
They're anxious, they're cyanotic, cool, clammy. You'll see JVD, and critically, this incessant, urgent cough that produces large quantities of that pink, frothy sputum. That sputum is the hallmark. It's fluid mixed with blood components being literally forced out of the lungs.
Okay, moving to assessment and diagnostic findings. There are standardized ways we classify the severity of this disease. Let's start with the one based on symptoms, the New York Heart Association, or NYHA classification.
Right, the NYHA system. It gives you a snapshot of the patient's current functional limitation. It's broken down into 4 classes, and you can see this in Table 25-1.
So, class 1.
Class I means no limitation. Ordinary activity doesn't cause any distress. Class 2 is a slight limitation. They're comfortable at rest, but ordinary activity brings on symptoms.
Okay.
Class 3 is a marked limitation.
Huh.
They're still comfortable at rest, but now even less than ordinary activity causes discomfort.
Right.
And Class 4 is the most severe. They can't do anything without discomfort, and they have symptoms even when they're just sitting at rest.
So that's all about symptoms. But the ACHA classification stages A through D is arguably more important because it guides therapy based on the structural progression of the disease, not just how the patient feels today.
Yes, and this is a really important shift. It focuses on prevention and intervention based on the disease stage. You can see it in Table 25-2. Stage A is purely high risk.
No disease yet.
No structural disease, no symptoms, just risk factors like hypertension or diabetes. The goal here is just aggressive risk factor control.
Then stage B means we have structural changes, but the patient hasn't felt anything yet.
Correct. In stage B, there's structural heart disease, maybe a low EF from a past MI, but the patient is asymptomatic. This is a critical time for us to intervene. Treatment here expands to include those cornerstone medications like ACE inhibitors or beta blockers to try and prevent symptoms from ever starting.
And once symptoms appear, they're in stage C.
Stage C is structural disease with current or prior symptoms. This is where most of our diagnosed HF patients are. We manage them aggressively with diuretics, aldosterone antagonists, sodium restriction, and we start thinking about devices like ICDs.
And the end of the road is stage D.
Stage D is refractory, and stage HF. The symptoms are just persistent despite everything we're throwing at them. This requires specialized care. We're talking palliative care, fluid restriction, and discussing things like VADs or transplantation.
So on to the diagnostic workup. The one test that gives us the definitive answer about function and classification is the echocardiogram.
The echo is non-negotiable. It's what determines the EF, which then concerns the diagnosis and classifies the type HFrEF or HFpEF. And remember, diagnosing HFpEF can be tricky. It's often a diagnosis of exclusion, especially in older women with chronic hypertension who come in fluid overloaded.
And what about the crucial lab work? We talked about the pathology of BMPA, but what about its diagnostic value?
We check all the standard labs, electrolytes, kidney function, liver, thyroid, to rule out other things. But the BNP, the B-type natriuretic peptide level, is the critical diagnostic marker. High levels confirm that there's high cardiac filling pressure and ventricular stress.
So it can help you in the ER.
A rising BNP is a key signal of an acute exacerbation, and it helps you distinguish a cardiac cause of shortness of breath from, say, a pulmonary one.
Okay, let's transition to medical management, section 5. This is the heavy lifting, especially for HFrEF. The goals are pretty clear. Improve function, reduce symptoms, and delay progression.
And it all starts with lifestyle. A strict low-sodium diet, no smoking, no alcohol, and a graded exercise program. But pharmacologically, HFrEF treatment really hinges on 3 big categories, which are detailed in Table 25-3.
And it's important for the learner to know which drugs improve survival and which ones just manage symptoms.
That's a key distinction. Let's start with the symptom relievers, diuretics. We use loop, thiazide, and aldosterone antagonists.
Okay.
So diuretics are critical for managing that volume overload. They improve symptoms like dyspnea and edema. Loop diuretics, like furosemide, are the most powerful for rapid diuresis in severe cases.
And the nursing monitoring of diuretic therapy, described in chart 25-2, that's where the real work happens because of the risk of electrolyte imbalance.
This is a major exam alert. Loop and thiazide diuretics dump potassium. They cause hypokalemia.
Right.
If your patient is on digoxin, that low potassium significantly increases their risk of life-threatening digitalis toxicity. It's a huge deal.
And on the flip side,
if your patient is on spironolactone, a potassium-sparing diuretic, and an ACE inhibitor, both of which hold on to potassium, you have to watch closely for hyperkalemia and bradycardia.
We also have to watch for signs of just too much fluid loss and kidney injury.
Exactly. Rigorous INO, daily weights. You're watching for dizziness, orthostatic hypotension that tells you they're getting volume depleted, and you have to track their BUN and creatinine for signs of acute kidney injury. And a practical tip, always give oral diuretics early in the day so the patient isn't up all night with nocturia.
Now for the survival drugs, the angiotensin system blockers. ACE inhibitors like lisinopril were the first big breakthrough.
Right. They block the conversion of angiotensin the first to the second. So they promote vasodilation and diuresis, which decreases both afterload and preload, and they actually slow that ventricular remodeling process. They decrease morbidity and mortality.
What's the main reason a patient might get switched from an ACE inhibitor to an ARB?
That persistent, dry, hacking cough.
The ACE cough.
It can be intolerable for some people. So for them, we switch to an ARB, an angiotensin receptor blocker, like valsartan. ARBs block angiotensin II directly at the receptor site, so you get similar benefits, but without that cough.
And the newest first-line therapy, the ARNI sacubitril valsartan, this is really revolutionizing HFrEF care.
It really is. The RNI is now considered first-line for symptomatic HFrEF because it has shown a superior reduction in cardiovascular death. It's a combination drug. It has an ARB, but is combined with a neprilysin inhibitor.
So what does neprilysin do?
Neprilysin is the enzyme that normally breaks down our beneficial natriuretic peptides like BNP. So by inhibiting it, we keep those good peptides around longer, which enhances their effects of vasodilation and diuresis. You're fighting the RAAS cycle more effectively.
And what is the single most important safety rule for a nurse regarding RNIs?
You can never give an RNI within 36 hours of an ACE inhibitor.
Why not?
Because combining them significantly increases the risk of severe, life-threatening angioedema. That transition has to be managed very, very carefully.
Okay, moving to the third cornerstone. Beta blockers, like carvedilol. It seems so counterintuitive to give a drug that slows the heart to a patient whose heart is failing. Why are they so critical for survival?
Because they block those chronic, harmful effects of the sympathetic nervous system. That constant adrenaline rush causes remodeling and strain. Beta blockers reduce the heart rate and the afterload, which allows the ventricle more time to rest and fill. This actually improves long-term survival and can even reverse some of that remodeling.
And the key nursing challenge here is the titration.
Yes, you have to start them at an extremely low dose and titrate up very, very slowly, often over months. Patients frequently feel dizzy or tired or bradycardic at first. The nurse has to provide relentless education and reassure them that these initial side effects are expected and the long-term benefit is worth it.
Let's cover a couple of important adjuncts. First, ivabradine.
Ivabradine is unique. It's a focused heart rate reducer. It works directly on the SA node. We use it as an add-on for symptomatic HFrEF patients who are already on the max dose of their beta blocker, but still have a resting heart rate of 70 or higher.
And digoxin. It doesn't reduce mortality, but it still has a place.
Digoxin is a positive inotrope. It increases the force of contraction, so it helps with symptoms and it decreases hospitalizations.
Yeah.
The major clinical alert here is digitalis toxicity.
Right.
So you need to be suspicious if your patient reports anorexia, visual changes like seeing yellow-green halos confusion, or if they have significant bradycardia. And again, low potassium makes toxicity much more likely.
And a quick but critical warning about a common over-the-counter habit?
Yes. NSAIDs, like ibuprofen, must be avoided by all HF patients.
All of them?
All of them. NSAIDs cause sodium and water retention, and they constrict the renal arteries. This is a must-know patient teaching point.
So when a patient crashes into acute decompensation, we rely on IV infusions, usually in the ICU.
Right, we use IV inotropes and vasodilators. Inotropes like milrinone or dobutamine are powerful muscle strengtheners, but they're used cautiously because some are associated with increased mortality risks in long-term use. Milrinone is potent because it's also a vasodilator, but you have to watch closely for hypotension and arrhythmias.
And regarding adjunct therapies, let's just drill down on the low-sodium diet.
The standard is a strict 2 grams sodium restriction per day, and often a fluid restriction as well. And chart 25-4 offers a key insight for education. Patients need to know about hidden sodium.
It's not just the salt shaker.
Not at all. It's in processed foods, canned items, flavor enhancers, water softeners, even over-the-counter meds like antacids. You have to teach them how to read labels.
Finally, let's touch on the device therapies, specifically the ICD and CRT.
Okay. The implantable cardioverter defibrillator, or ICD, is put in for primary prevention of sudden cardiac death. especially in patients with an EF below 35% who are prone to lethal arrhythmias.
And cardiac resynchronization therapy, or CRT.
CRT uses a biventricular pacemaker to fix electrical conduction delays.
Can you explain how that works in simple terms for a learner?
Sure, in some HF patients, there are electrical defects, like a left bundle branch block, that cause the ventricles to contract out of sync. It's this inefficient wobble that wastes energy.
Okay.
So CRT places specialized leads in 3 spots: the right atrium, right ventricle, and a lead targeting the left ventricle to resynchronize the contraction. This allows for a much more forceful, coordinated squeeze, and that can significantly improve cardiac output in the right patients.
All right, we're shifting now to the nursing process for the patient with heart failure. This is where theory becomes action, and the focus here is overwhelmingly on 2 things: assessing fluid status and promoting patient self-care.
The initial assessment is all about uncovering signs of progression. You're looking for the cardinal symptoms: dyspnea, fatigue, edema, and you're quantifying them. How many pillows does the patient need to sleep? Have their rings or shoes gotten tighter?
In the physical exam, let's talk more about assessing right-sided failure beyond just looking at the neck. We need to actively check JVD and that specific technique, hepatojugular reflex.
Right, so JVD is assessed at 45 degrees. The more active check, the hepatojugular reflex, confirms that increased venous pressure. You apply firm manual pressure to the right upper quadrant over the liver for about 30 to 60 seconds.
Okay.
If applying that pressure causes the neck vein distension to increase by more than a centimeter, that's a positive finding and strong evidence of right-sided failure. You're essentially forcing more fluid back into the venous system.
Now, for the single most crucial, non-negotiable, high-yield nursing assessment intervention, we have to drive home.
Rigorous fluid status monitoring via daily weights.
Daily weights.
The weights have to be standardized. Same time, usually first thing in the morning, same clothes, same other scale. We are looking for those early trends that tell us the diuretic regimen is failing before the clinical symptoms become severe.
And what are the concrete numbers that mean you have to call the provider immediately?
The nurse, and you have to teach the patient this too, must immediately notify the provider for a 2 to 3 pound increase in 1 day, or a 5 pound increase in 1 week.
That's 0.9 to 1.4 kilos in a day, or 2.3 kilos in a week.
Exactly. Those numbers are the alarm bells. They signal acute fluid retention that demands a medication adjustment, usually an increase in their diuretic dose.
Okay, moving to nursing interventions. How do we manage activity intolerance without causing the patient to just completely decondition?
We teach a paced lifestyle, avoid prolonged bed rest. The goal is to alternate
And for managing fluid volume acutely, positioning is a fast, non-drug way to help.
Positioning is key to decreasing preload and relieving dyspnea. The patient should be positioned upright, high head of bed. But in acute decompensation, like pulmonary edema, the immediate action is to position the patient upright with their legs dangling over the side of the bed.
Why dangling?
Gravity pulls that venous blood down into their legs, which decreases venous return to the right heart, and that rapidly reduces lung congestion. It's a quick fix.
Let's talk about the psychological side, controlling anxiety. There's a critical safety alert here.
There is. Anxiety is physiological in HF because of hypoxia and all the catecholamines. But the quality alert says, avoid restraints in confused or anxious HF patients. Any resistance or struggling dramatically increases their cardiac workload, which just makes the failure worse.
This brings us to the biggest challenge of all, adherence and health management. The sources have a fascinating insight in Chart 25-5 about patient behavior that should fundamentally change how nurses approach education.
This is a high-impact clinical pearl. Research shows that non-adherence, which is the leading cause of readmission, is often not just forgetfulness. It's often a deliberate self-care strategy.
Meaning what?
Meaning patients, especially older adults, may adjust their own medications based on how they feel, or they might stop them because of side effects they feel the provider was too busy to discuss.
So the nurse's job isn't just to hand them a checklist.
Exactly. Our job is to engage with their rationale and problem solve with them. We have to use teach-back methods and really try to understand their perspective on their meds.
So let's nail down the essential teaching points from Chart 25-6, the home care checklist. What are the must-knows before discharge?
They have to understand HF is a chronic, manageable disease. They have to be able to state the name, dose, schedule, and potential side effects of all their medications. They have to know the 2-gram sodium restriction and how to read labels.
And the weight.
Daily weight monitoring is paramount. And they have to know the red flag symptoms to report, that 2 3-pound weight gain in a day, increased swelling, a persistent cough, or increased shortness of breath.
Transitional care is that final safety net.
Right. Evidence-based care means a follow-up visit with the provider within 7 days of discharge and a follow-up phone call within 3 days. This tight time frame lets us intervene early before a small problem becomes a readmission.
And given the progressive nature of this, end-of-life considerations need to be discussed proactively.
Absolutely. Advanced directives, palliative care, hospice. These discussions have to happen while the patient can still make decisions. And for patients with an ICD, it's a critical nursing responsibility to make sure there are instructions for ICD and activation at the end of life to prevent inappropriate painful shocks.
In our final section, we're moving to management of complications from heart disease, starting back with that life-threatening acute pulmonary edema. What are the first 3 things a nurse does when they walk in that room?
First, assess airway and breathing. Then, get them on a cardiac monitor and pulse oximetry. And then establish IV access.
And position.
Position them upright with their legs dangling to decrease that preload.
Yeah.
Oxygen goes on immediately, usually a non-rebreather mask, or you might escalate to CPAP or even mechanical ventilation if it's severe.
And what's the immediate drug intervention?
Through that 5E, you're going to push a potent loop diuretic, usually furosemide, and an IV vasodilator like nitroglycerin to rapidly reduce volume and pressure. The nurse has to stay with the patient, manage that severe anxiety, and be ready to put in a Foley for rigorous I&O monitoring.
Let's briefly reinforce the dangers of aggressive diuretic use.
For sure. When you diurese that hard, you risk hypokalemia, which increases the risk of arrhythmias and digoxin toxicity. Or you risk hyperkalemia if they're on potassium-sparing drugs. You also watch for hyponatremia and, critically, rapid volume depletion leading to hypotension and a rising creatinine.
Okay, next complication. Thromboembolism. Why is the HF patient so vulnerable to clots?
Slow, turbulent blood flow. Stasis. That's the primary risk. It's particularly bad in patients with atrial fibrillation, where the atria don't contract properly and blood just pools in clots.
And those clots can travel.
They can cause ischemic strokes if they go to the brain, or a pulmonary embolus, a PE, if a DVT from the legs travels to the lungs. That's why anticoagulants are so common in this population.
Let's detail the acute complication of pericardial effusion leading to cardiac tamponade. This is an obstructive shock state.
Right. Tamponade happens when excess fluid builds up in the pericardial sac, and it literally compresses the heart, preventing it from filling. The result is severely decreased cardiac output and obstructive shock.
So what are the cardinal signs the nurse needs to watch for?
The signs include chest pain, severe dyspnea, JVD, and hypotension. When you listen, you hear distant, muffled heart sounds. But the highly specific finding is pulsus paradoxus.
Explain that.
Pulsus paradoxus is a drop in systolic blood pressure of more than 10 millimeters of mercury when the patient inhales compared to when they exhale. The compression from the fluid prevents the heart chambers from expanding fully during inhalation, causing the pressure to drop.
And how do we manage this emergency?
Pericardiocentesis, the emergent aspiration of fluid from the sac, usually guided by an echo. A successful procedure is confirmed when you see a simultaneous drop in their central venous pressure and an increase in their systemic blood pressure.
Our final topic is the absolute emergency, cardiac arrest and CPR. What are the primary mechanisms of arrest in this population?
Arrhythmias are the most common cause. Ventricular fibrillation, VF, or a systole. We also see a lot of pulseless electrical activity, or PEA, where the EKG shows a rhythm, but the heart isn't actually generating a pulse.
Upon recognizing an arrest, high-quality CPR is the priority. Remind us of the key parameters.
Immediate activation of the code team, then high-quality chest compressions. The rate is 100 to 120 beats per minute, depth of at least 2 inches. You have to ensure full chest recoil and minimize interruptions. And you switch compressors every 2 minutes to prevent fatigue.
When do we defibrillate?
If the rhythm is shockable VF or pulseless VTAC, rapid defibrillation has to happen within 2 minutes. Survival drops so quickly with any delay.
For Advanced Cardiac Life Support, ACLS, which drugs are the workhorses in an arrest, as seen in Table 25-4?
Epinephrine is the primary vasopressor for all the non-shockable rhythms, like asystole and PEA, and we use it in shockable rhythms after the initial shock. Amiodarone is the antiarrhythmic we use for refractory VF or VT that doesn't respond to the shock and epi.
And the crucial component of post-arrest care that can improve neurologic outcomes.
Targeted temperature management, or TTM, for comatose patients. This involves cooling the core body temperature down to a range of 32 to 36 degrees Celsius for at least 24 hours. The goal is to decrease the brain's metabolic rate and hopefully improve their neurologic recovery.
We have covered an enormous amount of ground in this deep dive into heart failure. If you're a nursing student, let's just condense this down to the three non-negotiable clinical anchors you have to carry forward.
Anchor number one. Management is a battle against that neurohormonal cycle, the RAAS and SNS. Your survival drugs are the beta blockers and the angiotensin blockers. Your ACEs, ARBs, and ARNIs.
Okay.
Anchor number two. Rigorous fluid assessment is everything. Obsess over those daily weights. Know that a 2 to 3 pound increase in one day is the red flag that demands action.
And number three.
Anchor number three. Your role in patient education and transitional care is absolutely critical. The sources confirm the biggest obstacle to care is often the patient's own deliberate choices. So you have to address their concerns and make sure they know the sodium restriction and that 3 and 7 day follow-up plan.
That distinction, that non-adherence is often a form of self-care, that's probably the most powerful behavioral insight in this entire chapter. It really shifts the nursing responsibility from just checking boxes to truly collaborating with the patient.
Exactly. And that brings us to the final thought. Considering the incredibly high rate of psychological distress in HF patients, how might a nurse integrate mental health screening and support directly into the daily weight check and medication review to maximize functional status, knowing that psychological distress often precedes clinical deterioration? That holistic integration, that's the future of advanced HF care.